At the Ortho Show, we are proud to partner with Shoulder 360. Today's episode of the Ortho Show is sponsored by Shoulder 360. Shoulder 360, the conference, provides a comprehensive shoulder course focusing on shoulder repair and reconstructive surgery. Shoulder 360 will always continue to redefine the way we think about surgical education of the shoulder. They focus on new methods to engage attendees, encourage participation, and utilize new educational technologies for a more interactive experience. There is no death by PowerPoint here. Shoulder 360 aims to educate the spectrum of healthcare providers caring for patients with shoulder disorders. The target audience is practicing surgeons, surgeons in training, nurses, physician assistants, and physical therapists. Shoulder 360 wants participants to learn about the newest and best ways to treat their patients while enjoying a setting designed to foster lifelong friendships and collaboration. Trust me, the venue is awesome as well. Don't forget to use our promo, OrthoShow10, that's ORTHOSHOW 10, the numbers for your 10% discount when registering. Okay, everyone, this is a fun episode. Dr. Stephan Pill, who's an orthopedic surgeon, he's a shoulder specialist down in Greenville, South Carolina. I've had the opportunity to work with Stephan on a number of podiums. He's a great speaker, very passionate about education. He has tremendous educational experience. He just quotes all of these great shout outs for all the people that he's worked with in his career. And now he's passing that on to the next generation as a fellowship director at the University of South Carolina in Greenville. We talk about some of the things that we're both very passionate about, and he gives a really great detailed explanation about the cool, innovative things that we're seeing in rotator cuff surgery as well. So anybody out there that has rotator cuff disease, this is going to be a great episode for you. We know you're going to like it. Dr. Scott Sigman, #follow the fro.
From Medical Media, this is The Ortho Show.
Hello world, Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon, here for another episode of the Ortho Show podcast, where everyone knows we bring you the best of the best in orthopedics. We are super excited. We have Dr. Stephan Pill on with us today. We're going down to the southeast of the United States, where he is an associate professor at the University of South Carolina in Greenville. He's also in private practice at the Steadman Hawkins Clinic of the Carolinas, where he is the associate fellowship director. He is an orthopedic surgeon who is a sports medicine and shoulder reconstruction specialist. And when he talks, I listen. Stephan, what a pleasure it is to have you on the show.
Thanks so much, Scott. I've been looking forward to this for a while now.
Yeah, well, we're always thrilled to be able to bring on innovative thought leaders, people doing really cool stuff. But we always start at the beginning, which is where we want to go. I'm assuming you're somewhere in the red half of the state of Pennsylvania, but tell us where you were born, sort of where you grew up, and when this whole doctor thing sort of came along, because you have an interesting path, which is a little unique to most, which I want to get to.
Yeah, sort of took the scenic route. So I was from the great state of Delaware, small wonder, and coming through high school, I said, well, I like sports and I like science. I'm going to be a physical therapist. So I went to a program in northern Pennsylvania where I was able to get a bachelor's and a master's in 5 years, where I was studying essentially physical therapy. That was when physical therapy was at the master's level. And I did that for a year, but I kind of reflected back and said, what I really enjoyed the most was the cadaver lab and learning sort of how things were put together and seeing the anatomy and how it was applied. So I said, you know what, maybe surgery would be a really cool path for me. So right when I was ready to hang a shingle as a therapist, my friends thought I was crazy, because I basically started all over again and went back to biology and chemistry school, and then got into medical school, and then knew orthopedics was going to be my calling all along. And then sort of, I feel like as an orthopedic surgeon with a physical therapy background, I kind of use, my PT knowledge a lot, my surgical knowledge a lot, and sort of in shoulders is where I've sort of landed on in terms of my clinical practice. And I feel like it's a great blending with the non-operative care that we see and continue to use, and have great collaboration with our therapy colleagues, but then being able to do the surgery side of things is a great challenge. It's humbling. It's been a great fun path for me.
Yeah, definitely a unique pathway. I can say that, and what I also think is kind of unique is the way you chose to make that decision quite rapidly. So in our research, you were a pretty darn good NCAA athlete in soccer, which probably
Yeah.
sort of helped you sort of steer in this direction of both physical therapy and orthopedics, right? I'm sure there was an injury or two along the way, and you get to meet cool people and sort of get you drawn in. But I think I've met a number of people that have done other pathways, but they've done their career for a period of time, and then they
Mhm.
decide to make the transition. For you, it sounds like you literally got your master's, and then did you practice at all as a physical therapist while you were going back to school and figuring this whole thing out?
Yeah, well, the one thing about the accelerated program that we had, getting a master's degree in 5 years, we skipped some of the general biology and chemistry. So what I had to do was go back and take sort of undergrad classes, during the summer while I was, doing things. So I was actually working as a PT, but taking, general
Mm.
biology, learning about xylem and phloem and, what enantiomers were and things like that. So it's not the most, fun, early summer years doing PT and then college classes. But I just sort of, I've always been one of those people that, I see something that I like and I just kind of know that that's what I need to go and do to be happy. And I've always enjoyed sort of the journey to get there kind of thing. I know that's sort of cliche, but I really enjoyed the learning of PT, and I learned learning within medical school. I would do it all over the exact same way, because I think having kind of an interesting twist and a way to see things, I think adds a lot to it. And probably was you mentioned that I was a soccer player. I mean, it is sort of that, empathy for athletes that you sort of have, and that sort of drive that you see through sports that you use on a daily basis as well.
Yeah, no, and I love the fact of the synergy of the two, and then I'm sure your communications with your physical therapist as a surgeon are much more direct than mine are, and than many most surgeons, I would think, because of your expertise, having a master's in physical therapy and having been a practicing physical therapist as well. So and you must have done pretty well in xylem and phloem and all this other stuff because you got into University of Pennsylvania for medical school. That's pretty cool.
Oh,
And
I loved my medical school. It was, Philadelphia is a great place to be and train. And yeah, I loved my friends at University of Pennsylvania. And then I loved it so much I stayed on for residency there, and had a lot of great mentors early on. And
shout him
so
out. Neil Sheth must have been
Neil
going strong
Chef
at
was
that
there.
time.
Yeah. Yeah. Good friend. He was a co-resident with me. There was, gosh, it just goes endless. I mean, I think that, there's, residency, I think is a special time for a lot of us, but we're all still pretty close. And what's interesting is I was going through right at the time where it just happened to be a lot of people interested in shoulder were going through the residency around the same time. So like, just older than me would be like, Joe Abood. And then, you have, Serena Namdara, you mentioned, okay, and Akwanze, there was Jason Shu, there was, so many that I still run into. Eric Ricchetti was there. Just so many, friends that I still see on a regular basis. That it was just fun to be around all those brilliant minds, all at the same time, all with similar passions. That then now I still continue to see on a regular basis. Every meeting I go to, I still run into the same people.
Yeah, no, and it's fascinating because 2006 was when you're starting your residency, and we just had
Yep.
Mark Frankel on, and we've got the history now of the development of shoulder as a specialty, and it was really
Yeah.
sort of in the mid 90s when things were really starting to blossom, right?
That's right.
Arthroscopy starting to really start doing some stuff. The reverse total shoulder is now starting to gain momentum. And so there was it was a real blooming time for shoulder at that time. And I love the names, all of the amazing names that you've listed here as people that are your colleagues and people that you've stayed in touch with. So you have an amazing, you stick around there for 8 years or whatever, 9 years in Philadelphia at that point, but it's off to, for a fellowship. And so tell us how the process. So you went to Stedman Hawkins of the Carolinas, and who was there at that time? Because the Stedman Hawkins world has been evolving, almost on an
Yeah.
annual basis as to where people were and what they were doing. So who was there helping out at the time?
Yeah, so it was really there was a resident that came down to the fellowship just shy before me. Todd Mitcher's his name. He's in practice in Pennsylvania, and he was technically a good resident, and he said, go down there, you'll love Hawk. And I said, sure, let's go down to South Carolina. I had no idea what I was getting myself into. I mean, I've always had been in the Northeast and the hustle and bustle of all that, and said, gosh, I'm going to go down to South Carolina and I'm going to be, considered this weird, high strung outsider. But it's a really welcoming community here in Greenville, and just sort of really fell in love with the warmth of Hawk. Anyone that's met, Rich Hawkins just knows that he's first a family man, so he has all of his priorities straight. He's the utmost of an inquisitive mind, so he kind of questions anything he doesn't quite have a grasp on. He teaches in a very kind of neat, we call it the Hawkratic way. I wanted to do sports, but I wanted to have sort of like a specialty within that. And I thought shoulder was very intriguing, and that there's so much that we don't know. And you're kind of alluding to that. It was just getting to be that, arthroscopy was really kind of an exciting thing. And arthroplasty, I was kind of mentored by, Jerry Williams, Matt Ramsey up at Penn, and Charlie Getz and Russ Huffman and Dave Glazer, just people that said they are all great people, and all got me, inspired to kind of be like them. And so it's technically a sports medicine fellowship, but he made sure that on the diplomas it said sports medicine and shoulder reconstruction, because 6 months out of the year you're just doing shoulder. So I saw that's a great fit for me.
Southern hospitality. It's a little different in the way in which they look at their family, bringing together as a fellowship, and the people that have trained there. So then, but apparently South Carolina wasn't good enough, so you had to go one state north, and you joined Ortho Carolina for a while, 5-6 years. You were in practice up there as well.
Yeah.
So, but that sort of like, that's where the job was when you finished fellowship that seemed appropriate?
Well, I always thought, and this is not to knock people that are just true, pure academicians that all the way just go through academia and just make it look really smooth. I don't know if I was ever smart or bright enough to do that. So I kind of said, what, let me go. I've learned from, some of the best of the best. Now let me go and just kick my own tires, kind of learn my own way. Because I always thought, gosh, if I'm going to teach people, how to operate, I don't know if I just want to take what I've learned and regurgitate that back. I sort of took a blending of all my mentors and sort of figured out what was working best in my hands. So I knew I was going to always end back up in academia. I wasn't anticipating maybe that was somewhere in the 5 to 10 year mark. Mike Kissenberth, who's down running the fellowship here, he called me one day and said, well, Hawk's gone now. He still kind of chimes in, but he's not clinically practicing. And we had this guy, named JT Tokish. No, I'm kidding. Of course, everyone knows JT. He was just this huge shoes to fill. So I said, well, I'm not going to be able to fill in where JT left, but I said, well, I can go and maybe just give it my best. And so here it was, Hawk to JT, and then here I come in, and I said, well, I'll just, I kind of learned some tricks, and I do have, a big heart. I love teaching. I love being around, residents and fellows. So I've been here now for, since 2018. And I've kind of transitioned now from that busy private practice to just a very subspecialized practice within shoulder, and lots of teaching, and, kind of ramping up on the whole research side.
Yeah, no, I mean, it's a natural transition from Dr. Hawkins to JT to Stephan Pill. I mean, it's like, who else are you going to go with? I mean, there wasn't any choice.
I don't know. Maybe hopefully in 20 years, it's going to take me that long to get a running start, to get anywhere close to what they were doing. But, I feel like, you can't build Rome in a day. We're just, we're trying to do just, keep pushing along. We've got a nice, research database going. We've got, we always have very inquisitive, great fellows that come through. They keep me young and asking good questions. And so it's been a lot of fun.
So tell me about the breakdown. So tell our listeners about the breakdown of your practice. I mean, how much of this are you doing? All shoulder at this point, just arthroscopic and shoulder recon, some trauma? Are you doing any of the, as Paul Favorito would say, the inferior extremity as well? Or, what do you got? What do you got
funny.
for us?
Oh, that's good. I'll have to use that.
Yes, exactly.
Yeah, so as you may know, I mean, now when you hang a shingle as a sports medicine fellow, and now you're in practice, it's almost, I hate to say it, but the new general. I mean, you typically take care of a sports team and their, moms and dads, uncles, and, they just come to you with whatever they have, going wrong. And so many of our, residents now are trained so well in sort of the basics of orthopedics in general, whether it's, trauma and some, some arthroplasty. So I was doing when I was in private practice, I was definitely doing a bit more shoulder than other things, but it was sports and arthroplasty and trauma. And I was essentially the only orthopedist in this bedroom community between Greensboro and Winston-Salem. So I was, taking care of most things. And people love that little, community. They didn't want to drive, just the 20 minutes down the road. Coming from the Northeast, it was funny. People would drive hours and sit on the Schuylkill Expressway to go see their surgeon for 5 minutes and be in traffic. Here, it's like, I would say, look, there's no traffic. Head down the road. In 15 minutes, you'll be with a foot and ankle specialist that is way better at doing this than I am. And then they say, yeah, but Dr. Pill, we'd like you to fix my Achilles and then my bunion after that so I just sort of said, well, okay, if you have the trust in me, I'll never compromise your care, but just know that there's some high volume, but I'll do my very best. And so I sort of got into that mentality. So when I talked to Kissenberth, I said, well, just so you know, like I left as a sports medicine fellow, but now I'm like, kind of a jack of all trades, but expert of none. I mean, I'm up here just, like a gerbil in a wheel, just doing case after case after case, and just and then so I talked to the chairman here, Kyle Dre, and he said, well, that's perfect. He said the new sports fellow is a generalist, so we want you to do that. Come down here and still run your general practice and teach the sports fellows that you can make that work. And then it wasn't but a couple days here where you come into academia and, all the subspecialists are like, yeah, no, you're not.
No, you're going to be the shoulder guy. We've got the ACL guy already. So start honing on your shoulder skills.
Exactly. So, shoulder was just kind of like the path of least resistance. Once I got here, it was what Hawk did. It's what JT did a lot. It's what, kind of, if there is a subspecialty need, it was that. So, and I just said, look, if I'm going to be teaching, doing research, there's just not enough hours in the day to be in, get into the nitty gritties of all this stuff. So I just sort of owned and said, I'm just going to have to commit to this shoulder thing. And it's what I loved anyway. So it was a natural thing. And so now I'm essentially 100% shoulder. And I probably do, an equal split between arthroplasty and sport, probably a little bit more arthroscopy. Maybe it's, 65-35 or something. It seems like each year the arthroplasty is growing a little bit, but I want to keep the sports up there because it's the arthroscopy is certainly so much fun, but yeah, it's 100% shoulder now.
And I'm assuming you do left and right shoulders. That's
still do both.
Haven't gotten there yet. Okay,
and
that's good.
Yeah, don't discriminate on age. I'll do young and old too, but definitely left
good.
and rights.
And it's funny. I mean, as you mature in your practice, it becomes easier to you said before your expert list, but to become an expert and to feel really comfortable, right? The last place that I'm having anxiety now in my clinical practice is when I'm in the operating room. That's when I'm having the most fun because I've eliminated the surgeries that I used to do maybe once every 3 or 4 months. Let somebody else that's been doing it, 3 times or 4 times a month, let them do it. So then you can be focused, you can be really comfortable, you can educate and really provide, that education, which you really is important to you. So, all right, so good. So it's all shoulder. You're edging into a little bit more recon, but let's start with rotator cuff. What is exciting you in rotator cuff surgery? Now, remember, my mother Judy is listening, so we have a lot of lay people that want to hear about this stuff, and they don't want to know all the fancy words and terms. So keep it simple so that my mother Judy can understand.
Yeah. Well, I think that, what I'd say is when I was in sort of a general practice and you're doing a little bit of everything and you might fix, 30 rotator cuffs in a given year, you might see a couple of them fail, because, if 30% of them, don't heal right, as the literature would suggest, maybe 30 to 40%, that's a pretty small number. If the denominator is small, the numerator is small, everything's just the same fraction. So not to get too technical, but I wasn't seeing a whole lot of a problem. But then you come into a subspecialized practice where you're just seeing shoulder after shoulder, and now you're getting into hundreds of repairs. Well, then that numerator becomes a real number because you're saying, gosh, if 30% of hundreds are failing. Gosh, my waiting room, why am I? And it almost felt like, am I doing something wrong here? Like what's happening? I never had this many, patients that would get stiff or still have pain or not have the strength that they had hoped for and stuff. And so, then I sort of really, that's what really makes you kind of think. And it's like, then I just realized, aha, that's just because I'm doing more. And the complications ever, change in terms of its rate of some doing more of this exact surgery. If anything, maybe I'm reducing my rate by what you said. If you become subspecialized, I think you do learn some tricks to get you out of trouble sometimes. So it was, initially it was a bit frustrating. I felt like I was starting to get more efficient, just, fixing lots of rotator cuff tears, but yet despite our best interests, there were in efforts, there would just be some that would not do well. And so
Yeah,
it,
I mean, it's like, for example, just not to cut you off, but it's like,
yeah,
okay, Dr. Pill, you're getting on our flight. We're flying from Boston to Chicago. We have good news for you. There's a 70% chance that we're going to be able to land the plane in Chicago and
yeah,
everybody's going to be okay. I'm like, I'm not getting on that plane, right?
yeah,
But yet here we were operating on these complex rotator cuffs with a 30% failure rate. I mean, that's real.
yeah.
That's not good, right?
No, I'm
We had
not.
to come up with some ideas about doing something better than that.
Exactly. I'm not boarding that plane. And
No.
the other thing is, and now that you're the subspecialist, you're considered like the expert. So, people are like, well, if you can't figure it out, who's going to figure this out? So I've just kind of owned it to say, okay, well, I see the sort of like the slow, sculpture of my practice. And I'm kind of, if I'm going to get into the weeds here with this, let's really dive in. And I think, the issue is, as you were mentioning, sort of the explosion of arthroscopy and the excitement with it. I think early on, all of the focus was just on the mechanical repair aspect. So it was, okay, what's the pullout strength of a rotator cuff anchor? So if we put an anchor within the bone, how strong is it? Okay, let's use a suture in that. How hard is that? How hard can we pull on that string before it snaps? So it was all on, how many anchors, how, should we do a single row of anchors, a double row? And it was all on the mechanics. And I think all along, if you take a biologically, sick tendon and sew it down, it doesn't matter how many sutures or strings or anchors or whatever, you're going to do there. It's a sick tendon, and some of them fail.
I love what you just said because I just posted on LinkedIn the other day. For the first 20 years of my clinical practice, I was a mechanic. I got under the
Yeah.
hood, something was broken, and I put in some bolts and some screws and some stuff, and we did a mechanical fix, right? And then in the last 10 years, I'm starting to use my biology degree
Hmm.
from Tufts University, and literally, I've recognized, man, you got to put in some biology. You can't just do a mechanical fix on this stuff, whether it's this thing called the ACL in the lower extremity don't work on anymore, whether it's the rotator cuff. We've had these high unacceptable failures. And so we're a biologic mechanic now. So what kind of stuff are you using to add in biology to help with your sick tendons?
Yeah, and I think with that, just to double back, I think that like I don't even like the word rotator cuff tear, because I mean there are occasional tears where you slip on a banana peel and you stretch your shoulder and your cuff tissues, but the tears, but the vast majority is a slow melting away through the aging process that the tendon just sort of like melts like an ice cap. And so that's why it's not healing great, because we're putting back a melted away tendon. So I don't even like the word tear. It should really just rotator cuff disease or something. So that just hones in on the biology. So the majority of rotator cuffs that we see are not the traumatic ones, that it's a slip and fall. Most can't remember when they hurt that. And that's because it's a slowly thinning out, diseased, tendon that's going to eventually just, puff right off the bone and then sort of like float in there in the fluid and get even weaker. And then we can't just put that bone back, that tendon back on the bone. So I think I actually was in a meeting with you, Scott, and you said at some point somebody said, well, what do you think the greatest breakthrough or what we're going to be doing in years to come? And you said at that time we're going to be augmenting a whole lot more rotator cuffs. And I was sitting on that panel. I really soaked that in because I was kind of young on the augmentation pathway, but now after seeing both sides, I'm truly a believer. And now we have to do research to show that that's what we need to do. And then we need to show the insurance carriers that it's worth the extra price to put augmentation So basically what we're talking about there is don't just sew the piece of minced up tendon back onto the bone, expected to be, or tendon back on the bone, expected to be a 20-year-old tendon again. We need to often, sew it back onto the bone, but then add to it biology. And there's a lot of nifty little, implants that we can use now. One that I'm using now is sort of this resorbable synthetic that has collagen in it, and collagen is the building blocks of tendon. So basically, it's a little, essentially an orthopedic duct tape that we can put down on top of into the repair, and then it's got the building blocks of tendon within it. And I think we're going to prove that over time, many of these tears, many more than we think, really need that level of augmentation.
I'm going to go out on a limb here, and I'm waiting for Gettleman to yell at me. Levine will probably call me an idiot too. But I'm telling everybody the CPT code. So for our listeners, there's always a code that's used for surgery, which is 29827. Within a matter of 5 years, commercial payers are not going to allow surgeons to do a rotator cuff repair without some sort of augmentation, because the data is going to show the significant improvement in healing of our surgeries compared to what we're doing now.
I completely agree. And that's why I like being in this academic teaching role, because with that becomes a lot more subspecialty training, because, adding a lot of these implants onto, I think, just arthroscopically repairing some of these larger tears can be enough of a learning curve. And then adding, these various implants on top, it's a fun time to be in the teaching world and the research world, because there's a big, there's a learning curve with that. And so, now rotator cuff surgery is done by many surgeons all across the country. But if we're going to make it so that many more are going to be, needing augmentation, it's a nice time to be in the teaching role, because I think there's a whole lot of learning that's going to have to get done here.
All right, so we got to bring up one of your classic lines, and I love the slide. I took a picture of it when we were at our meeting together, where we were talking about the BioBrace implant for ComMed. But there's a lot of augments out there for our listeners. Smith and Nephew has the Regeniten. Anika's just come out with the Integrity. There's a couple of others that are out there too. I apologize if I'm not naming all of them, but you use the Chinese menu, which I love, because all the kids now don't know what we're talking about, right? Yeah. But in the days when we were growing up, you go to a Chinese restaurant, you get one from column A and one from column B. We're not trying to offend anybody here. This was truly what it was at the time. Mm-hmm. And so tell our listeners about how you're using the Chinese menu to decide how you're going to fix in a simplistic way to how you're fixing these tears.
Well, this is why we force our fellows to do a lot of clinic time with us, because, a lot of fellows want to come and they just want to operate. But, every tear comes with its own particular challenge. And it really, kind of learning all those little subtleties is so important. So, yeah, what I was alluding to there is, when I was a fellow, it was kind of like an airplane menu where you got the chicken or the beef or whatever. So you either got a repair or PT, and those are your choices. You come in with a rotator cuff tear and you got one or the other. Now it's like, gosh, there's just so many choices. I mean, there's, you get, okay, if you're gonna have a repair, you've got, different anchor selections, all suture anchors, solid anchors. You've got, tapes and ribbons and sutures, and then you got, what configuration of anchors you're going to put in, and then now you have these tendon transfers and augmentation implants, and skin patches and balloons. People are now putting in, if they can't repair it, sometimes they'll say, out of heck with it, I'll just put a big balloon that fills in that space, and because there's nothing else to fix in there. Some people are saying that it's not even worth fixing, and maybe we should just replace the shoulder. So I think, as patients come through, there's little subtleties. It's like a big, kind of algorithm. It's like that little Plinky game in Price is Right. Now, that you just watch the Plinky thing go down, and different factors make it go a different direction. And then it's a matter of getting everyone into the right bucket in the end. And I think that's why shoulders are so fun. Because
no two are the same. I mean, that's what, I mean, ACL surgery is pretty much ACL surgery. I'm doing the Bear implant now, but the bottom line is, you put the place in the right place is what you do. Rotator cuffs, every one, you got to be, was it going to go this way? Is it going to go that way? And as you said, we're going to take one from this section and that from a different section. So I completely agree. Look, Stephan, this is awesome. I mean, I love your passion. You're an amazing podium speaker. I always look forward to presenting with you. Education is so important to you, innovation in the rotator cuff space, as well as arthroplasty. We'll have another time for a different conversation on the arthroplasty world. There was some crazy news that came out today from within the shoulder world as well, which we're not going to talk about. But, look, it's a real pleasure to have you on. Always look forward to spending time with you for sure.
Yeah, I'm a big fan of yours, Scott. Thanks for inviting me on. I really appreciate it.
Again, brother, you are now officially an Ortho Show alum. We love that. And Grace, we got to start working on our swag. We've not been sending out our merch as much as we need to. We're going to make sure we get you something. I'm going to see you at Shoulder 360.
All right. Yeah, I'll be there.
All right,
and
perfect.
I'll wear your merch proudly.
Oh, it's coming, brother. You know it. This is Dr. Scott Sigman, #FollowTheFro, host of The Ortho Show. Till next time.